So then we have one photography. So geotag कोई भी नहीं होगी, मैं खुद गई। लेकिन ये तो geotag we have started the YouTube link. The live has started. A very good afternoon to all of you. I welcome Dr. Sameer Gupta sir and Dr. Sudhir Singh sir to have agreed to devote some time to this worthy cause. May I now request our HOD sir, respected Professor U.S. Singh sir, to please welcome the guests and officially start the CME. So,
on behalf of all the faculty and the residents of Department of Pathology, I welcome Professor Sameer Gupta, Department of Surgical Oncology, Commonwealth, Cambridge, United Kingdom Fellow, and I will say one of the finest surgeon in Surgical Oncology Department, and Professor Dr. Sudhir Singh, who is again from Radiation Oncology. And we are very much thankful to you, sir, that you have said yes to come to deliver your very important talk. On this very important day, I would like to remember most revered and visionary Honorable Vice Chancellor, sir, Lieutenant General Dr. Bipin Puri, who has been a source of energy and also very supportive in all the academic activities. And I will like to thank and again would like to remember in reverence and gratitude the name of Professor Dr. Ashutosh Kumar and Professor Dr. M. Goel, whose blessings has made the day. As you know, the World Ovarian Cancer Day is celebrated on 8th of the May. So that will be tomorrow. To mark that important day, Professor Riddhi Jaiswal came to me and she talked about it is basically her brainchild to have a small CME on this important topic of the cancer of the ovary. And within a couple of hours, she did it, and we are all enjoying today's program. As you know, the ovaries are very important. They are very vital to the life. And if you see the ovaries in all the total hysterectomy cases, we are seeing the ovaries. And we see a lot of disorders, different kind of nature of the disorders in ovaries. And one of them is the different type of the tumors, both solid and the cystic. And if you go further, the disorders are majority of the time, as you know, maybe anything, but majority of the time it is benign, intermediate, or the malignant lesions. And today our talk by our esteemed guest from KGMU is about the cancer of the ovary. And it is a great joy when our own faculty from KGMU, interdepartmental, they are willing to deliver their talk. Basically, their experiences in this hospital, which is nothing but our experiences. So I will request you, sir, to please start with the. Thank you.
Sir, sir, may I request Professor Rajesh Singh sir to please welcome Dr. Sudhir Singh sir with the floor. Thank you, sir. Now may I request Professor Rashmi ma'am to please welcome Dr. Sameer Gupta sir.
जो भी जियो टैग लिया कैसे जाता है?
Thank you, ma'am. We now have our first guest speaker on board, who's an electric personality, very busy. So let's hear him out. Sir, please.
Thank you, Riddhi. इस आगे किससे बता दो। ठीक है। So good noon to all of you, and basically I'm not here as the guest faculty because this is my institute, our institute, and what I have done in the last 3 years. Who is the examination going postgraduates who are going to appear in the examination? Okay. It was my duty to interact with you people, but I lost this opportunity, and finally I was summoned by Professor U.S. Singh sir, and today I am bearing this my responsibility. And in these 20 minutes, I will just behave like the faculty of the Department of the Pathology. So you have to bear with me, and believe me, these will be the most pathetic 20 minutes for the departmental residents. Okay. So first of all, my talk was the ovarian malignancies, and this is to be best dealt by the Dr. Samir Gupta, because in the ovarian malignancy, there is a very little role of the radiotherapy as well as the chemotherapy. The mainstay of the treatment is the surgery, but somehow, so we have divided our talk so that we can just avoid the repetition, and I will deal with the staging and some background and medical management, and Samir will deal with the clinical presentation, diagnostic workup, and the surgical part. So this is not my original presentations, and I was helped by Dr. Abigail Leju, who is senior resident in State Cancer Institute, and Dr. Arunima Ghosh, who is senior resident in our department. So I think so that you people are EGPG, please just come forward, because you have to just come in the next slide. जो भी examination going है वो आ जाए जरा 4-5 लोग कौन है? हाँ. नहीं बतानी. अच्छा चलो ठीक है, अगर बता पाएंगे तो I think so that you people are well aware about this slide, because most of the time in the ovarian malignancy, the surface epithelial constitutes the major burden, that is about the 65 to 70% of the tumor burden. Okay, so my this slide is first is the serous tumor, and because you people are able to see the some gross changes in a specimen. So again, the first slide, this is the serous tumor. So can you differentiate the where is actually the tumor is? कौन है तुम्हारे 5-6 जो वो नाम बता दो अपने. Okay, so this is the scale, and how you will define this tumor? This is the serous tumor. And here it is mentioned that is the low-grade tumor, and basically these low-grade tumors are the clinical significance is that they are less sensitive to the chemotherapy in comparison with the high-grade tumors. So because you have to augment my knowledge, then I will just supplement your knowledge. So let me tell very clearly whether you people are able to see any pathological feature, that is the malignant feature in this picture or not. Okay. So here, by this specimen, you people can identify that this is a case of the C ovary. By seeing just is the gross specimen, you people would be able to tell that this might be a case of the C ovary. So what are some other differential diagnoses that you can keep in your mind? Okay, I'm just making your life more easy. And just coming to this, I think so this microscopic picture. So this first question is used in the last one. How you will define this serous adenocarcinoma? Actually, how do people just define that this is the serous adenocarcinoma by seeing this picture? And how you will differentiate? The second one is the mucinous adenocarcinoma. So how this serous adenocarcinoma and the mucinous cyst adenocarcinoma are quite different. And how you will define? Yes, this will be the serous and this will be the mucinous cyst adenocarcinoma. आके बता दो नहीं मुझे, तभी तो कह रहा था वहां से नहीं बता पाओगी। एक और आ जाओ पीछे से, आप लोग बैठ जाओ।
Serious study में carcinoma basically arises from the lining of the fallopian tube. तो लाइनिंग हमें वैसी मिलेगी।
तो fallopian tube की लाइन कैसे पहचानते हो कि कौन सी fallopian tube की लाइन?
एक तो कॉलमर टाइप की होती है।
दिखाओ ना इसमें कहाँ पे? इसमें नहीं है, इसका मतलब
लो पार्ट है, लो म्यूसिनस इंटेस्टिनल जो लाइनिंग होती है, म्यूसिन फिल्ड कॉलमर लाइनिंग, वो एफिशिएंट हो रही है पैपिलरी स्ट्रक्चर में भी, पैपिलरी आर्किटेक्चर है और ये फाइब्रोवेस्कुलर हो रहा है।
And how can you just differentiate this endometrioid?
Endometrioid like glands हैं।
सर बेलोग्रानुलर पैटर्न बोलते हैं, सब बेलाइस होते हैं एंड ग्लैंड्स दो फॉर्म होना। और सर जैसे ये बता रहा है क्या लाइन
ये सिर्फ क्यों है नहीं है और एंडोमेट्रियोइड क्यों है नहीं है?
ये एंडोमेट्रियोइड कौन सा है?
एंडोमेट्रियल लाइक ग्लैंड्स को रिजेंबल करता है।
उसके बाद और लास्ट वाला
ये सर कार्सिनोमा।
तो सेल्स साइटोप्लाज्म में सब क्लियर साइटोप्लाज्म।
And what actually is the hobnail pattern?
The nucleus seems to come out of the cytoplasm. The nucleus is coming out of the cytoplasm.
जो इंग्लिश सेल्स है उनमें सब साइटोप्लाज्म क्लियर होता है, जैसे इसमें।
Okay, these are the some other feature. One is the sex cold stromal tumor, and what actually the call axonal body?
ह्यूमन में eosinophilic secretions होते हैं, उसके सराउंडिंग ट्यूमर सेल्स होते हैं।
पर ये जो सेल्स है ये सिक्रेशन पिंक कलर में है और इसके अराउंड सब सेल्स है। सर ये पैटर्न में होता है, इसको बोलते हैं कॉर्नर ये अक्सर ट्यूमर में सर ये स्पेशली लगता है।
Granulosa cell tumor, granulosa cell tumor.
This is here mentioned. There is a granulosa cell tumor, and what actually?
सेल कैसी होती है?
न्यूक्लियर ग्रोविंग अगर एडल्ट टाइप का है तो उसमें ग्रोविंग में मिलेगी, कॉलेक्सना बॉडीज में मिलेगी। या जुवेनाइल टाइप का तो उसमें नहीं मिलेगी। कॉफी पिन एडल्ट टाइप ग्रेनुलोसा सेल ट्यूमर।
And what is the cedar dual body?
Cedar dual body seen in York sac ट्यूमर, उसमें सर बीच में ल्यूमन होगा, फिर ट्यूमर सेल्स होंगे, फिर सिस्टिक कैविटी के अंदर होगा, फिर ट्यूमर सेल्स होंगे। और सर ग्लोमेरुलर बॉडीज भी होंगी।
Chanchal, you are satisfied with the answers? So then you have to work hard because examination is very near. Okay, you people can take your seat. Okay, I think so that this is the only slide that is some kind of some has importance in regard of the pathology, because here there are some high grade tumors and some low grade and endometrioid clear cell and mucinous tumor, and there are some specific mutations that are related with this high grade, low grade endometrioid clear cell and mucinous tumor, and BRCA1 and RAD51C, D, part and LB2, they are more common in the high grade tumors, serous tumors, and while the KRAS, BRAF and HER2 and PIK3CA, they have the more significance in the low grade tumor. In the endometrioid and clear cell, we see the L1A and PIK3CA, and in the endometrioid, the CTNP1 and P10, and in the clear cell, the next one is the ZNF217, and in the mucinous, they are usually KRAS positive. So this is the two pathway model of the epithelial ovarian carcinogenesis, and where we have just divided this malignancy into the type 1 and the type 2, and type 1 is the usually low-grade malignancy, and the type 2 are the high-grade malignancies. And they are in the type 1, the P53 status is the wild, and high-frequency P53 mutation is found in the type 2. And the platinum-sensitive malignancies are the usually type 2, that is the high-grade serous malignancies. So now we are coming to the staging. Sir, staging important होती है आपके यहाँ पर? Okay, so you can just see this is the pictorial representation of the staging. Here you can see the stage 1A, that is the cancer only in the one ovary. And stage 1B, you will see that this is the cancer in the both ovaries. And the capsule is intact and there is no tumor on the ovarian surface. And why in the what happened in the stage 1C? Stage in the 1C, it can be further categorized into the 1C1, 1C2, and 1C3. If there is some surgical spill, then it will be the 1C1. And if the capsule ruptured before the surgery, or if the tumor is on the ovarian or the fallopian tube surface, it will be the 1C2. And if we are finding the malignant cells in the ascites or the peritoneal washing, it will be the 1C3. And if we will just see the T2 stage, and then tumor is involving in the one or the both ovaries, and there is some pelvic extension, but the tumor is up to the pelvic rim only. And if there is the extension of the implants on the uterus or the tubes, it will be 2A, or the extension of the implants in other pelvic tissues will be the 2B. So the last one, what are the stage 1 staging? Stage 1 आप भी खड़ी हो जाइए. Stage 1, 1C1, 1C2, 1C3. 1C1. आप और कोई मत बोलिए. 1C2. This was the live slide presentation, so you can't say no. That means that you are not vigilant. This class was organized, your examination is shown here. This is the really hardest effort of our Professor U.S. Singh, sir. You cannot take this, what we can say, the 40 minutes so lightly. Yes. आप ही से कह रहे हैं पीछे. Okay, now you should be very vigilant in this slide because I will ask again the question after the next slide. Okay, so then the tumor, if it is again takes just visited extension or implant on the uterus or the fallopian tube, then it will be the 2A, and if in the other pelvic tissue, then it will be 2B. Okay, this is the 3A and 3B and 3C. And because the FIBO is having some other staging purpose, and in the DNM classification, the 3A is the T3A and 1, and 3B is the T3B and B, and the 3C is the T3 and 1. If again it will be categorized in the T3A is the A1 and the A2. A1 if the metastasis is up to the 10 mm the greatest dimension, and if the metastasis is more than the 10 mm greatest dimension, it will be the A1-2, and in A2 is the microscopic extra pelvic above the pelvic ring peritoneal involvement with or without positive retroperitoneal lymph nodes. So now we are coming to the 3B. It's the macroscopic peritoneal metastasis beyond the pelvis less than 2 cm with or without positive retroperitoneal lymph nodes, and in the 3C it is the macroscopic peritoneal metastasis beyond the pelvis more than 2 cm, including extension to liver capsule or spleen without parenchymal involvement of those organs and with or without positive retroperitoneal lymph nodes. So stage 4, all of us know that stage 4 is usually the metastatic disease, and if this is the pleural effusion, then it will be the 4A, and other metastasis will constitute the 4B. So now the treatment schematics. As I said, the primary mainstay of the treatment is the surgery, But somehow in the low-grade malignancies, if they are the stage 1 and the stage 3, this is the area of the controversy. But in the higher grade and early stage disease, we usually prefer the adjuvant side. We usually prefer the taxane and carboplatin irrespective of the observation, in comparison of the observation. And in the high-risk category, we usually give the 6 cycles of the chemotherapy, and while in the low-risk disease and the grade is the higher, then we keep the paclitaxel and carboplatin doses up to the 3 cycles. And in all other stages, again the taxane and carboplatin is usually given for the 6 cycles, and this taxane and carboplatin drugs are given on with a duration of the with a gap of the 21 days. That means the 1 cycle will be up to the 3 weeks, and paclitaxel and carboplatin, these are the very, what we can say, just like the broad spectrum antibiotics, the broad spectrum anti-cancer drugs, because the taxanes and the platinum group, they are the most common drugs that are used to deal with the solid malignancies. And role is there of the adjuvant chemotherapy, and again, if there is the advanced disease is there, then one can go up to the 8 cycles of the chemotherapy. It totally depends on the subjective response and the toxicity, because most of the time the chemotherapy molecules are really very toxic, and they usually cause the myelosuppression and acute effects such like the hypersensitivity reactions as well as the nausea, vomiting. And for the chemotherapy, this is the cyclophosphamide doxorubicin. These were the earlier molecule, and people have also tried the melphalan, but the dramatic change comes after the platinum chemotherapy, because platinum is having a very good response, and particularly as I told in the advanced as well as in the high-grade malignancies. Carboplatin is usually given in case of the renal failure because it is the less nephrotoxic drug, less neurotoxic, and it is also having the less hematogenic potential in comparison of the cisplatin. And combinations of the paclitaxel and carbo, this is the preferred and worldwide accepted regime for the CA management. So I'm just avoiding these statistics and some trials. Basically, the ACCENT trial. This was the adjuvant chemotherapy in the ovarian neoplasm, and that basically established the role of the paclitaxel and the carboplatin in management of the CA ovary. And targeted therapy, among the targeted, one molecule that is the bevacizumab. Bevacizumab is the VEGF inhibitor, so it acts on the various VEGF 1, 2, 3 as well as the FGFR receptors also. And bevacizumab, earlier this molecule was tried in the non-small cell lung cancer, but now it has a very good role in the CA ovary as well as in the CA cervix. And bevacizumab is usually given only in the very advanced disease as well as in the metastatic disease. And this drug, after the completion of the paclitaxel and the carboplatin, this drug can be kept as the maintenance therapy. Radiotherapy, it is having a very small role, only just in the palliative setting. Earlier, the people were using the whole abdominal radiations at the adjuvant treatment, but with the advancement of the medical drugs such like the targeted therapy as well as the chemotherapy, now this role has been also. For some palliative setting, the radiotherapy can be given. It's a toxic protocol. Basically, there is the whole abdominal radiation. The problem with the radiation usually occurs whenever there is a large field of the radiation is there. There is the more acute toxicity as well as the chronic toxicities. So it is only of some kind of the palliative intention. So it's a field that was used earlier. First, there is the whole abdominal radiations with some shielding to the kidneys as well as to the liver, and then we can just go for the pelvic boost. After the completion of the treatment, there is some follow protocol, and in the first 2 years, we usually follow the patients 3 monthly, and then once in a 6 months, and then annually after the 5 years. And investigations, I think some people deal it. And the recurrent malignancies, ovarian cancer, the 70 to 80%. The bad thing is that of the ovarian malignancies, 70 to 80%, they usually recur. And the survival after the recurrence is usually less than the 30%. And first, we have to just see whether the patient is platinum sensitive or the platinum refractory. If the platinum sensitive disease is there, then we can take the re-challenge with the platinum-based chemotherapy in case of the recurrent carcinoma ovary. these are the some new drugs that have been arrived in the management. Is the PARP inhibitor. Basically, they are effective in the BRCA mutated cancer only because they work in the PARP. PARP, you know that PARP is basically it is the enzyme that is responsible for the DNA repair, and after this inhibitions in the BRCA deficient tissues, they usually drug acting, and there are the three drugs which are available right now: the olaparib, rucaparib, the niraparib. And germ cell tumors, it's just like the counterpart, just like the seminoma is the germ cell tumor in the ovary is the dysgerminoma. The good thing is that it occurs in the early age group, that is the second to the third decades. But this tumor is quite radiosensitive, and the treatment we were using in the epithelial malignancies. We have the platinum and the taxane group, that is the paclitaxel and the carboplatin as medical treatment. While in the germ cell tumor, this is the PEP. B stands for the bleomycin, E stands for the etoposide, and E stands for the cisplatinum. And this germinoma can be treated as radiations with the help of the radiation mobility. And usually we give the 25 gray radiations to the whole field, and then we usually prefer the 10 gray as the boost. So 35 to 36 gray is the quite sufficient to deal with the germinoma. So in the summary, Samir is having the upper end, that is the mainstay of the diagnosis, staging, and initial treatment of the ovarian cancer in the surgery. And platinum is usually used in the high risk for the advanced disease cases. And we have the good newer molecules like the olaparib, niraparib, and the rucaparib, as well as some anti-angiogenesis like the bevacizumab. And radiation is just for the palliative intentions, and it has a very limited role in its management. Thank you.
Thank you so much, sir. Please have your seat. And thank you for stimulating the brains of not only the residents but the faculty as well. May I now invite Dr. Samir Gupta, sir, to deliver the surgical part of management of ovarian cancer. So please.
Pathology.
Good afternoon, everybody. It's a pleasure to be here. Thank you, US Singh sir, Riddhi ma'am, to have this opportunity. And so, talk of the day is carcinoma. Sorry.
So there is really for point evidence. So he will just leave so we can present the evidence.
Sure.
I'm sorry for this interruption. Dr. Sudhir has to leave for a court evidence. So may I request Suresh Babu sir to present a memento as a token.
Thank you, sir.
Thank you, sir. Thank you, Samir sir. Please continue.
Sure, no worries. Yeah, sure. So, cancer ovary, it's a multidisciplinary disease basically, managed by surgeons as well as by medical oncologists. Radiation definitely has a limited role. So, after the tough exam that Sudhir was subjected the residents to, you can now sit back, relax. My talk would primarily be surgical. The objective being to familiarize you with the terms that you may encounter while the forms are filled. Primary cytoreduction, secondary, interval cytoreduction, HIPEC, so all that. The objective is to just give you an overview of cancer ovary risk factors and their management. So unfortunately, this is the kind of disease that we encounter, advanced ovarian cancer, and you can see the deposits all over the peritoneum, over small bowel, and so these are the kind of diseases which are really a nightmare for the surgeons. So it's the seventh most cancer in women, and unfortunately 70% of all cases are diagnosed in advanced stage, wherein surgery takes a back seat and chemotherapy is what is given before we take up the patients for surgery. So 5-year survival rate, despite doing an optimal surgery, is unfortunately less than 30%. And as alluded to by my previous speaker, it's an epithelial cancer, which is the worst type and the most common type of ovarian cancer. But we also have germ cell tumors and sex cord or stromal tumors. But for the topic given today, I'll primarily be dealing with epithelial ovarian cancers. Primary peritoneal carcinoma and fallopian tube cancers closely mimic and are managed on the lines of epithelial ovarian cancer. So the risk factors: increasing age, family history, a very strong risk factor, threefold increased risk when a first degree relative has a history of a documented ovarian cancer. So it's imperative that we take that history properly regarding the family history as when the patient first comes to us. Nulliparity, infertility. PCOD is not exactly a risk factor for ovarian cancer. There is no level 1 evidence for this, but it's still in the gray zone. Heritable mutations, they account for 5 to 10% of epithelial cancers. The strongest risk factor being associated with BRCA1 mutation compared to BRCA2. So it's about 1:4, 4 times greater risk of cancer, not only breast, but also ovarian with BRCA1 mutation as compared to BRCA2. Strong protective factors, obviously prophylactic salpingo-oophorectomy, high parity, OCP use, which has its own downsides, but as far as ovarian cancer is concerned, it has a protective role. There were 2 potential hypotheses which were floated as far as risk for ovarian cancer concerned. Patients who have had prolonged menstrual history, early menarche, late menopause, more ovulation, more exposure of ovary to estrogen surges, greater potential of mutations within the ovarian surface epithelium, and another was LH and FSH derived surge. So these are the 2 pathways whereby the ovarian cancer spreads within the abdomen, and the reason why it spreads so much within the abdomen by the lymphatic pathway, but also through exfoliation of the clonogenic cells which gets implanted all over the bowel, mesentery and omentum. So these are the various kinds. I think you would be more familiar with the various types than me, but these are the various types of cancers that we commonly encounter. The epithelial ovarian cancers, mucinous, which are associated with CEA levels as compared to CA125 levels, clear cell with a worse prognosis, and transitional cell tumors as well. So the tumor markers that are commonly associated with should be monitored all throughout the treatment course for ovarian cancer: CA125 and HE4. The unfortunate part about CA125 is that it is elevated only in 50% of early stage disease. So as far as early stage disease, that is the tumor confined to the ovary, CA125 doesn't help us much as far as confirmation of diagnosis is concerned. But in advanced disease involving the omentum, mesentery, ascites, pleural effusion, it is elevated in 80% of the cases. So thereby it helps us in assessing not only the response to neoadjuvant chemotherapy, but it also helps us in post-operative follow-up as well. Unfortunately, low sensitivity may also be elevated in some benign conditions like a PID, pelvic inflammatory disease, or endometriosis. HE4 is a relatively new kid on the block, slightly higher sensitivity and specificity for differentiating between benign and malignant ovarian masses as compared to CA125, and these two taken together, CA125 and HE4, they are quite informative. Then there are various scores which help in assessing the risk of malignant neoplasm, like a ROMA score, risk of ovarian malignancy algorithm, which takes into account, it's a formula-based score, which takes into account CA125 levels, HE4 levels, as well as menopausal status. And thereby you calculate a score which predicts the risk of malignancy or the prognostic value. So these are the terms that we need to be familiar as far as CA ovary is concerned. When you get a ovarian neoplasm for biopsy, maybe you can specifically ask the surgeon what was the CA125 level, what was the HE4 level, may help in coming to a diagnosis in case of borderline cases. Clinical presentation, mostly it's incidental adnexal masses in early stage. First investigation is obviously an ultrasound or a transvaginal ultrasound. The factors which help in determining between benign and malignant, whether it's a solid mass or a cystic mass, pure cystic mass, whether it's simple or a complex cyst, that is combined solid and cystic component. And among the complex masses, features being thick-walled with septations, with solid elements, with increased vascularity on Doppler. Signs and symptoms are quite vague. Usually patients present to us in advanced stages with gross abdominal distension, ascites, early satiety, abdominal pain, weight loss, cachexia. DD of advanced CA ovaries, abdominal tuberculosis, or a appendiceal mucinous carcinoma. So diagnostic workup, we begin with the USG, but for a proper staging workup, at least a CECT abdomen is needed. Not only to assess the nature of the ovarian neoplasm, but also to assess the spread of the disease within the abdomen, extent of omental involvement, peritoneal disease, any enlarged retroperitoneal or pelvic lymph nodes. Tumor markers for all epithelial ovarian cancers, the standard being CA125 and HE4. CA, we routinely get it done for all epithelial cancers, but they're more valuable in mucinous tumors actually. For germ cell tumors, it's AFP, beta HCG, and LDH values, which tell us to great extent what kind of germ cell tumor we are dealing with. And for granulosa cell tumor, it is inhibin A. A word of caution, for a tumor confined to ovary with no ascites or omental disease, don't put in a needle to confirm the diagnosis. You don't need that. Either you get the markers done, that will give you the clue, or you advise the patient to go ahead and get operated. Because we're converting a stage 1A disease maybe at least into 1C1 by causing tumor spillage. So if a disease is confined to the ovary, no biopsy is recommended. Only when we have an ascites or an omental disease or a peritoneal disease, then obviously we can go ahead and get a biopsy done. Staging alluded to in great detail, but just to summarize it, stage 1 disease is confined to ovary, very good prognosis, very good 5-year survival rate. Stage 2 is limited to pelvis. Obviously, survival rate goes down. Stage 3 disease limited to the abdomen, but going outside the pelvis to involve omentum, mesentery, liver, spleen, diaphragmatic surface. And obviously, 5-year survival comes down to 30 to 40%. And stage 4 disease, when there is disease outside the abdomen. So I think that's an easier way of remembering it. Stage 1 confined to ovary, 2 confined to pelvis, 3 confined to abdomen, and 4th goes outside the abdomen. Optimal surgery is vital, the goal being optimal cytoreduction. And when we say optimal, it means the residual disease remaining behind. Ideally, there is no residual disease that remains behind, or it should be less than 1 centimeter. That's how we define optimal cytoreductive surgery. So what makes laparotomy, what are the steps for a laparotomy for ovarian cancer? The first thing you do for a early stage disease, that is stage 1 confined to ovary, you do a peritoneal cytology or a lavage after opening the abdomen and send it for malignant cell cytology, because if that's positive, it automatically upstages the disease to 1C. Random peritoneal biopsies from pelvis, from paracolic gutters, from diaphragmatic surface. Total abdominal hysterectomy with bilateral salpingo-oophorectomy is the standard surgical procedure, ensuring that the tumor is removed intact, avoiding tumor spillage. And bilateral pelvic or para-aortic lymph node sampling. If the lymph nodes are not enlarged, we don't need to go in for dissection, just sampling is good enough. And doing a omentectomy, either infracolic if there is no gross disease, or going ahead and doing a total or a supracolic omentectomy if there are omental deposits present. So that makes up the entire surgery for CA ovary. Objective or the aim of surgery being optimal cytoreduction with no visible macroscopic disease. So these are the various steps that I just alluded to. After opening, you do multiple washings. Then you take out multiple biopsies, at least 6 to 8 biopsies from bilateral pelvis, paracolic gutters, and diaphragmatic surface. Then you do a total abdominal hysterectomy and a salpingo-oophorectomy along with intact tumor removal, omentectomy, complete abdominal exploration, and lymph node sampling. So benefits of cytoreductive surgery, obviously patient comfort, better GI function, better nutritional status, and patient is more amenable to chemotherapy. Chances of chemotherapy succeeding, ensuring disease-free interval being longer is more if you do an optimal cytoreductive surgery. And obviously we are improving the overall survival. Contraindications to primary cytoreduction: if you are not able to grossly remove the disease, or if you are going in and you are sure that you will not coming out without leaving a disease less than 1 centimeter, in that case there is no benefit of going in. Either you're sure that you go in with an intent of leaving, either removing the disease entirely, or at least less than 1 centimeter of deposits are left behind, go ahead and operate. But if you have a gross disease involving lung, liver, porta hepatis, bony mets, might as well subject the patient to chemotherapy. No survival advantage is gained by operating patients and leaving behind gross disease. So this is just a summary of disease. Early stage, grade 1, 2 disease, just surgery is enough. But for any grade 3 disease or a 1C disease, after surgery, you need adjuvant chemotherapy. And all stage 2 disease and above, you need adjuvant chemotherapy. Special fertility preservation, as far as epithelial ovarian cancer is concerned, it has a very limited role. Very special cases, early disease, patient counseled about the need for a prolonged follow-up, only then you can go in for fertility preservation. But for germ cell tumors and sex cord tumors, which are very chemo-responsive tumors, early stage of presentation, there is a definite role for fertility preserving surgery for germ cell and sex cord tumors. But for epithelial ovarian cancers, it's very limited role in a very properly selected patient that you go in and do a fertility preservation surgery. Advanced stage disease is a problem. Optimal cytoreduction, difficult to obtain. Primary debulking surgery is when you go in and operate without giving chemotherapy. So obviously determinant of survival is ability to achieve maximal cytoreduction. I think this slide may clear up few things. So primary staging or cytoreduction is when you're going in and operating without giving chemotherapy, right? Go in, operate, no adjuvant chemotherapy. There we use the term primary cytoreduction or primary staging. But if we have an advanced disease, we give neoadjuvant chemotherapy and then operate. That makes it an interval cytoreduction, right? After NACT, assessing the response, assessing the fall in tumor markers, we think we can do a good cytoreduction. So that makes it interval cytoreduction. Similar is second look surgery. We have had very few cases where you do a primary staging, you find disease is advanced, you close it, give chemotherapy, then you do operate again. That's a second look surgery after giving patient NACT. If after doing a good cytoreductive surgery, completing adjuvant therapy, patient has relapsed or a remission, you again give chemotherapy and again go in for surgery, that makes it secondary cytoreduction. And there is no end to it. Tertiary, quaternary cytoreduction. You go on removing the abdominal organs. Difficult, but it is explained, it is doable. So that is your secondary cytoreductive surgery when you do it for a recurrent disease. And palliative surgery, obviously, for palliative indication, bowel obstruction, you do a diversion, that's a palliative surgery. So I think interval cytoreduction we already talked about. There has been a trial of interval cytoreduction following NACT versus primary debulking, and there is no major difference in overall survival. Important thing is to achieve minimal residual disease either by a combination of chemotherapy followed by surgery, or it could be surgery followed by chemotherapy. So greater than 1 centimeter residual disease, if we leave behind, that has no benefit on overall survival. So there is no benefit in just opening the abdomen, doing biopsies and coming out. Objective should be less than 1 centimeter residual disease or no gross residual disease that you leave behind. And within the gross residual but less than 1 centimeter category, the closer we go to no residual disease, longer is the median survival. And now few slides on HIPEC, that's the new buzzword. We are not started doing it in KGMC, but hopefully in near future we may start it. That's hyperthermic intraperitoneal chemotherapy, either by an open or a closed technique. And how it works, it's a combination of pharmacokinetic and molecular pathways, because it's the heated chemotherapy which is delivered in the abdomen. So heat increases the drug penetration to 5 to 6 mm. So it is said that all those residual disease which are there at inapproachable sites can be taken care of by this intraperitoneal installation of heated chemotherapy. Heat in itself has anti-tumor effects and increases the cytotoxicity of agents. Hyperthermia increases platinum sensitivity. So average time being 30 to 90 minutes, and it can take care of those small nodules up to 2.5 mm. So that's the basic premise on which this HIPEC or hyperthermic intraperitoneal chemotherapy works. You have to take care of this peritoneal carcinomatosis index, whereby abdomen is divided into 9 quadrants, and the tumor size from 0.5 to 5 centimeters. So the score ranges between 0 to 39. For all patients who are undergoing HIPEC, you have to have their PCI score beforehand, and you only do HIPEC after optimal cytoreduction has been achieved with surgery. You don't do a HIPEC with gross residual disease behind. So that's very important to understand. You go in, operate, do maximal cytoreduction, and only when you are sure that you have left behind either no residual disease or less than 1 centimeter, then you do a HIPEC. So you can see the omentum or the mesentery with deposits. So you open up the abdomen, use good retractors so that you have a good access, and here you can see the disease all over the liver, diaphragmatic surface, gastrohepatic omentum, greater omentum. So all this has to be first surgically removed before a HIPEC can kick in. So here they are removing all the diaphragmatic surface, doing a peritonectomy, right diaphragm, left diaphragm, and all this thing has to be removed. Peritonectomy has to be done. Hereby, tumor is removed from the right hemidiaphragm, as well as the Glissen's capsule over the liver is being removed. Taking care, you remove the peritoneal layer with all the deposits alongside. So here the diaphragmatic surface is all clean with all the peritoneal deposits being removed. So this is the gastrohepatic omentum, which will have the bile duct, hepatic artery, and portal vein on the right side. So you'll have to take care, dissect all the vessels carefully, and all this has to be removed en masse. And hereby greater omentum is already being removed. So all this is upper abdomen. In the lower abdomen, if we have deposits on the sigmoid colon and the rectum, you have to divide, do an anterior resection or an LAR. So along with THBSO, you also have to do an anterior resection and remove all this gross disease. And then obviously, after the disease all clear, you do a stapled anastomosis. And after you removed all the gross disease, then you put in the catheters, close the abdomen, instill the chemotherapy for 40, 60, 90 minutes, the various chemotherapy agents that we use. And after that, you remove these drains. These are the various agents which have been explored for use as a part of HIPEC. So there's another variant of HIPEC, which is called PIPEC, that is pressurized intraperitoneal aerosol chemotherapy. Instead of liquid being instilled in the abdomen, it is pressurized aerosol form of chemotherapy, which is instilled in the abdomen. This has more of a palliative role. So while HIPEC is done for curative intent after complete tumor removal, PIPEC is more of a palliative intent where the disease, gross disease is inside. You just hope that by instilling this, you may achieve some sort of a downstaging of the disease. So this was just to give you an overview of what HIPEC and PIPEC is as a part of surgical management. Thank you.
Thank you, Dr. Sameer, for that lucid talk and making us aware of what are the new entrants in the management of ovarian cancer globally and what we can offer at our university. May I again request Professor Suresh Babu sir to please present the memento. Dr. Sameer. So as we
move. As we have just heard our guest speakers, not actually guests because the meaning is Atithi and this was a planned event, so it was well with Tithis. We now move on to the question answer round, and I'm sure some residents have their questions. Rena is here. Rena, you want to ask some question? Dr. Sameer is there. All the pathology faculty members are there. Apurva, JR1. It was so nice to see you people coming up with questions. Now put them here. Ram.
Prior to the organism, prior to the enzyme.
It inhibits an enzyme, like inhibitor is meant to inhibit an enzyme. Yes.
This is the immunotherapy or chemotherapy.
Doesn't matter. So it's a selected indication only in patients with BRCA mutation. With the progression of disease on first line and second line chemotherapy, it can be used. So doesn't matter, but it's a oral chemotherapeutic agent, if you may call it, used only in a salvage setting after progression of disease on first line or second line chemo. Only in patients with BRCA mutation form.
Sir, would you like to come here again for these questions?
Yeah, would we? I would like to request you to please share your experience with early stage ovarian cancer so that onward ovarian cancer you can educate others about there are some red flag signs or anything which you encountered in your clinical practice which you would say that that is my degree for a workup.
I got it.
A patient has a first degree relative.
So first is obviously the family history. Any first degree relative diagnosed with ovarian cancer, you have to be vigilant about. All females in the family have to be vigilant. Least expensive modality being a serial ultrasound done every 6 monthly. That doesn't cost much. It's non-invasive. Any ovarian neoplasm, I'm using the word neoplasm, which could be solid or cystic, going more than 6 centimeters, especially in a postmenopausal female, should be dealt with seriously. Should have a proper staging workup with various markers like a C75 HE4. And if the mass is increasing in size or has suspicious elements to it like a combined solid cystic component or a complex cystic mass increasing in size gradually, along with those prodromal symptoms of loss of weight, abdominal distension, so that these kind of ovarian neoplasms should be properly investigated. The unfortunate part is that we in India, any ovarian mass comes, a half-hearted surgery happens, and in the hindsight, you get the markers done or a CT scan done. But for any ovarian neoplasm, especially in a postmenopausal female with alarming symptoms, simply doing an ultrasound and operating is not enough. You need a proper staging workup. You need at least a CT scan abdomen to document that the disease is confined to the abdomen or it has spread beyond to involve the omentum or the mesentery. You've got to get the markers done, C75 HE4, at least a chest X-ray done to say whether it is pleural effusion or not. Because if there is a pleural effusion, that makes it stage 4A disease. That kind of patient would need a chemotherapy first before going in for surgery. So, proper workup, then undergoing surgery at a specialist center which has all the options of surgery, chemotherapy, and if needed, HIPEC. I think that is the best option which ensures maximum survival of the patient. Then obviously proper follow-up after undergoing surgery.
Sir, what is the experience in your department as far as what stages are most frequently coming and what is the survival outcome with the treatment management?
So unfortunately, most of the patients who come to us are definitely stage 3 or at least stage 1C3 with ascites, right? So at least we hardly come across patients with just ovarian masses. We have them, but around 20 to 30% would be there with just ovarian masses, some elevated markers, no ascites, no mental disease. We go ahead and just operate those patients, send it across to you, and once you confirm whether it's malignant, then only we decide whether we give adjuvant chemotherapy or not. But around 60 to 70% patients are those stage 3 disease and above with omentum or mesenteric disease, disease outside the ovary, ascites, rundown patient. Then we do a cytology to confirm the diagnosis, and then we go ahead and give chemotherapy first.
So the survival outcome are matching the
Actually, they are maybe a bit inferior, not because of the disease biology is different, but the patient presentation at a stage where the patient is already run down, is cachexic, has advanced disease, and has no finances. So that makes the life difficult. Abroad, even if you come with advanced disease, at least you are ensured that either insurance take care of things, or in England, NHS take care of things, right? So at least you get the best treatment. So here, these combination of these factors makes life really difficult. Patient will receive 4 cycles chemotherapy, very good response, gone. Come back after 1.5 years, back to square one. So these kind of things makes life difficult. Or patients coming to us with just an oophorectomy done and not even biopsy sent. Or even if biopsy sent, then told that enough, your adequate surgery has been done, don't bother. These kind of patients, just oophorectomy done, come to us after 8 months, 1 year with a mental disease ascites. If they would have been referred in time, we could have done a complete second look surgery, did an omentectomy, hysterectomy. So if you have patients in time, equivalent survival. But combination of these factors make life difficult.
And then there are no reports sometimes to be this.
Yeah, just ovarian mass removed, thrown away, not even sent for biopsy. So that makes life difficult.
So what is the treatment modality for borderline CNS tumors? Just surgery or any?
Borderlines.
I currently mix up in a case. It's been borderline CNS tumor with microinvasion net with ovarian implants. There are gross and microscopic tumor growth on ovarian surface, and it is in books it is written that this can be there. अब इसको लो ग्रेड सीरियस कार्सिनोमा करेंगे तो पेशेंट स्टेज 2 में आ जाएगा और आप उसे कीमो देंगे, जबकि बॉर्डरलाइन सीरियस में कीमो नहीं देते हैं, उसके लिए साइड इफेक्ट्स रह जाते हैं.
Exactly.
इस सिनेरियो में क्या?
I think we have to explain to the patient that yours is a case which is not classical. There is a high risk of recurrence. I would err on the side of giving chemotherapy, not 6 cycles, but 3 cycles, right? 3 cycles of pegcetacoplan, explaining to the patient that you have an option of being on close follow-up with serial monitoring of markers, serial ultrasound, and or you give 3 cycles chemotherapy. That would not completely eliminate the chance of recurrence, but this is the best that can be done in the present setting, and obviously close follow-up. So every 3 monthly markers, ultrasound, and we have had cases, not one but many, biopsy reported borderline tumor. Intraoperatively, we were quite sure we are dealing with malignancy. I have had few patients specifically called up the pathologist, are you sure this is borderline? And yes, it is borderline. And within a year or 2 years, patient present with relapse. So you are not wrong. What you will report what you see, right? It's borderline. But we are reluctant in giving chemotherapy to these kind of borderline tumors, but more often than not, those patients relapse.
That's why they should be treated aggressively and they should.
I would say so, yes. Explaining to the patient that this is the thing, this is the best that can be done. It's up to you.
Sure.
Sorry.
After giving the new adjuvant therapy, sometimes we get the tumor which 90-95% variation network. इसमें what you want, we are not able to identify
The tumor
cells. So,
ma'am, my request and suggestion would be that you can ask the surgeon whether this was post NACT or not, one. And if it is post NACT, then rather than reporting it to be no tumor seen, you can say it's response to chemotherapy seen with 90% necrosis. So that will help us prognosticate the patient that your tumor was chemo responsive. You tend to have a better outcome.
should we bother about the typing of the tumor? कि हम क्या type करेंगे?
Ma'am, you can just, if you don't see a tumor, you can just report it as that. But it has to be mentioned as good response to chemotherapy seen, or document the percentage of necrosis. So that will help us in telling the patient that you received chemotherapy, you have responded well, your chances of relapse or disease-free interval will be more. So compared to a patient who, despite giving chemotherapy, is gross residual disease remaining behind, these kind of patients tend to relapse much more and much earlier compared to those patients who were given chemotherapy and surgery shows 90% necrosis or no residual disease.
Sometimes we get the thing in the ovarian, there is a whole tumor is necrosed, and in the peritoneal tumor is viable.
That's entirely okay. You can say ovary response to chemotherapy, no residual disease, but momentum shows disease, because that will help us in properly staging the patient. Because if we have a disease in the omentum, it's better if you report the size as well, because that changes the staging, right? Less than 2, more than 2. So if we get that information, at least we can tell the patient that you are stage 3C disease. You have to be in very close or strict follow-up. And if patient has been operated after 4 or 6 cycles, we would make sure we complete 8 cycles. So this is the kind of information which would help us in proper treatment for the patient, right? So ma'am, that's a bad indicator. It may just help us in telling the patient that you have to be in close follow-up. That's it. Exactly. So it's actually the entire picture that matters. For you, a proper history from our end, NSCT was given, this was the markers, they have fallen down to this level, and this is the kind of disease that we found intra-abdominal. And with your biopsy results, we can plan the adjuvant treatment in a better way.
But CA125 का जो है benign versus malignant oblique secondary, मतलब कितना high तक much हद तक high रहता है कि मतलब benign बोला जाए?
Sir, benign में it is, so normal values of CA125 is between 0 to 35. Different labs have different values, but yes, that's what I'm trying. So 35 to 45, 50. In infectious diseases like a pelvic inflammatory disease or endometriosis or these kind, it may be elevated, but those values are between, say, 3 times or 4 times the normal. So it could be 150, 200, 250. So patient coming with an ovarian neoplasm and a CA125 of 250, 300, we don't take it as malignant, right?
But in secondary.
Secondary means?
Secondary from other
Ma'am, sir, that also it's not grossly elevated. Grossly elevated, I'm talking when you see CA125 in thousands. And we see it in thousands, or at least in late hundreds, 800, 900, 4,000, 5,000.
If approximately 200 oblique 250 है, मतलब primary versus secondary को
I got it, sir. Sir, in that case, it is not only CA125 that matters. We have to take the antecedent history as well, no?
कुछ मिलेगा, जैसे हमारी कुछ केस थी जिसमें हमने secondary मतलब radial carcinoma दिया था, but ये था कि primary oblique secondary, ठीक है? But उसमें CA125 को हमने जब देखा तो CA125 approximately 200 है। तो ये जो primary बोला है कि
सर प्राइमरी तो नहीं बोल सकते।
प्राइमरी से नहीं बोल सकते, बहुत
डिफिकल्ट
जो है बहुत
confusing. तो उस केस में obviously we would advise to get all the scopies done, upper GI endoscopy, sigmoidoscopy, CEA values done. No complaints of any hematemesis, melena, bleeding para PR. Everything is negative. PET scan to be advised. Either that helps in picking up the disease, or if it does not, then we can term it as unknown primary. After PET negative, that is no evidence of primary anywhere, then we can send the patients to us and we can at least do a surgery and remove the ovaries and have that entire specimen being properly examined. नहीं होती है सर ऐसे
200 तक ही था, बट लेकिन उनका था कि प्राइमरी है कि सेकेंडरी, हमने बोला कि सेकेंडरी है, उसको ये पता है पेट स्कैन करिए कहीं ना कहीं बिल्कुल पता मिले, बट
हाँ तो मतलब आपको फिर उसका बेटर
कहीं कुछ नहीं मिलता,
तो आप फिर सर्जन के पास भेजिए, वो उसको ऑपरेट करके निकाल देगा ना। चांसेस यही है कि वो प्राइमरी कहीं है जो डिटेक्ट नहीं हो रही है, चाहे पेट से या किसी से, बट that is the best treatment that you can offer to the patient. आपने पेट करा लिया, कोई सिम्टम नहीं है, स्कोपीज करा ली, कहीं कोई प्राइमरी नहीं है, it may still be Krukenberg that you are dealing with, but at least you have the evidence behind you कि you have done the proper workup, no evidence of primary, only ovarian disease. Go ahead and operate, remove it, send it for a proper IHC now with a bigger specimen, and maybe that may help in treating the patient.
So when do we get neoadjuvant chemotherapy in germ cell tumors? Like most of the germ cell tumors, they come across and they are mostly necrosed. So what's the indication?
So actually germ cell tumor, the age profile is young females, mostly unmarried. So we get germ cell tumors between say age of 14, 15 to 25, 30. That's the usual age. And those kind of patients are really bothered about the fact that they want to preserve fertility. Parents are bothered more than the kid. So in that cases, then unfortunately, germ cell tumors go on to attain very large sizes with no antecedent symptoms. So you get masses of 15, 20 centimeters, no ascites, nothing. So there, we tend to give them chemotherapy knowing that chances of fertility preservation would be better. We will be able to remove a 5 centimeter tumor with a smaller incision in a much better way compared to giving an entire abdomen. We are opening up the entire abdomen and removing that 20 centimeter tumor with higher chances of spillage. So that is the thinking that goes behind. Knowing that it's a germ cell tumor, markers are elevated, we don't even go for an FNA because we'll upstage the disease. Large tumor, young female, markers elevated, give chemotherapy, get them down to smaller size, chances of fertility preservation would be much better, and smaller incision, which matters to those young females. So that's why.
Is there any difference on post-operative chemotherapy between mucinous or serous?
No, unfortunately, no. The standard is Pecli carbo is what we give. Mucinous are less responsive compared to serous, but as of now, the standard is same.
Or any other type like clear cell
No, for all these epithelial cancers, chemotherapy to begin with is more or less the same. Paclitaxel and platinum.
Presidents, any more questions? Isha, do you want to share?
So the question is again regarding neoadjuvant chemotherapy. Basically, in stage 1C relapse, is there any more neoadjuvant chemotherapy in stage 1C relapse? And also, I want to know that in which cases do we follow maintenance therapy? What is basically the goal of maintenance therapy? How beneficial is that basically?
So, patient with ascites, there is no contraindication for doing a primary cytoreduction. Are you getting me? There is no contraindication to go ahead and upfront operate the patient. But in our setting, the patient who presents with ascites are quite nutritionally depleted, one. And patients with ascites, what we have found is that when you operate those patients, drain the ascites, more often than not, chances of achieving a good complete cytoreduction are less because more often than not, disease has gone beyond the ovaries. That's why ascites is there, right? And post-operative complications in forms of prolonged ascitic draining through the drains or post-operative bowel obstruction adhesions are more. So, if a patient is well preserved, you can go ahead and operate the patient upfront with ascites, but more often than not, we give them patients chemotherapy. It helps in drying up the ascites. Patient is able to build up herself nutritionally better. She's able to eat better. And after 3 to 4 cycles, we reassess the patient with markers and CT scan. And more often than not, we find that all ascites has gone within 2 cycles. And that makes our life easier and also patient's life easier. In terms of post-operative complications are slightly less. So no contraindication for surgery in patients only with ascites, not with omental or a mesenteric disease, because that makes the patient stage 3. But only with ascites, you can go ahead and operate. But we follow the philosophy of giving chemotherapy first because of the kind of patients we get. So we encounter this picture quite often in our practice. Patient has been given chemotherapy, operated, adjuvant chemotherapy on follow-up. 1 year, absolutely fine. After 1 year, 1.5 years, you start seeing gradual rise in serum CA125 levels, right? But no symptoms to the patient. And it is well documented that biochemical progression precedes clinical progression by 6 months. So for up to 4 to 6 months, you can just have rising CA125 levels, but no apparent discomfort to the patient, and you get a CT scan done, no apparent disease as well. So if a patient is asymptomatic, instead of getting the patient in after every 3 months, we call those patients in after every 4 to 6 weeks. Get those markers done, see the rise. If say the first time marker was 50, it goes up to 100, no symptom, it's okay. Come after 6 weeks with markers again. If from 200 it goes up to 500, that's an alarming sign. Then you definitely have to start chemotherapy, get an imaging done. But from 200 it goes up to say 250 only with no symptoms, we don't start chemotherapy, again call the patient. Because the idea is, in a recurrent disease, curative surgery is very difficult, right? So the objective is to maximize the quality of life. So if we start chemotherapy at 200, survival, the disease would become refractory after 6 to 8 cycles anyway. So might as well hold your horses, give patient another 2 to 3 months because patient is asymptomatic, and then start chemotherapy. The objective is to maximize the quality of life and disease progression-free interval, if I may call it. So this is well documented. Biochemical progression precedes clinical progression by 4 to 6 months.
Anyone else has any question? For example, sir, we are living in a developing countries where patients are even told that patients are coming worse in the stage 3 or 4. The initial stages when younger. So is there something we can do to educate them or for patients? What are the preventive measures they can take?
Unfortunately, see, ovary, there are no risk factors like a diet or a smoking or an alcohol, nothing. So it's your genetic disease or your bad luck. So more than educating the patient, it is to educate the doctors at the primary level that once you see those ovarian neoplasms, might as well do a proper workup. If you can deal with it, well and good. If not, refer them to a proper setup where they can be handled. As far as patient is concerned, obviously, for family history, as I told you, if you know that in your family, you had your mother or your aunt or your elder sister having this kind of a disease, be more alert, get your ultrasounds done regularly, and any suspicion ovarian neoplasm encountered should be serially followed up with ultrasound and markers, and obviously at a specialized center where you can be advised the best time to go in, operate, chemotherapy, and whatever.
आपके जवाब देने वाले साथी तो चाहिए
वो इसीलिए चले गए चलिए मैम थैंक यू सर
So my job is almost done, but just to thank you, thanks each one of you for being here. I will just share 1 or 2 slides because, as sir said, Dr. Samir, ovarian cancer doesn't always shout. So we receive most of the patients in later stages. So we have to. And this CME was just a beginning in that path. So I was preparing for this, I went through an article which read on PubMed, a view from the family years after a loved one has died of ovarian cancer. And whatever data they gathered through questionnaires and interactions, they concluded this very important line: for them, the worst part of their loved one's treatment was continued chemotherapy, and a common unfounded fear was that another female member would likely die from ovarian cancer. So the clear intent of this CME was not just these people. Anyone who identifies, most of us would identify, of course. Nafisa Ali, former Miss India, who suffered from ovarian cancer, was fortunate enough to get treated. Another celebrity, Manisha Koirala, right? But these people had access to the very best centers like memory, Sloan Kettering and all. But we are not only concerned with these. Of course, we wish them the best in their life, but we are concerned with these people, each one of the female that comes to us, and offer whatever our university can. That was the concept of integrating the surgical, the medical management. And that's why we did not put a pathology lecture here, because the rest part we are all dealing with every day, right? So this event would not be possible without the guidance of HOD sir, support of my colleagues, active involvement of some of the residents, especially Shalini, Fatima, Manish, Mithilesh, Gulshan, and those who made it interactive, Mr. Farhan and Mr. Vinayak from IT Cell, Dr. Jagdish Narayan, Mr. Aditya from Kalam Center, Mr. Shivanshu from Media Cell, Mr. Pandey and Ashutoshji from Department Office, our honorable respected speakers, and heartfelt thanks to my family and each of the audience present in the hall as well as online. Thank you so much. Thank you so much. Now we can depart and get back to our